I want to point out what's going on here. We've got endocrinologists, cardiologists, and somebody who's seeing patients in a primary care setting.
Help.
But that's my question. What is the role of the cardiologist and the endocrinologist? You've been asking them for help now for a question and a half.
Sorry, I
and
didn't.
You know what I heard?
Right.
Oh, we're kind of vague on that. What is the role out there, in your view, for these experts?
Well, I think that in the very challenging, difficult to manage patient, then I think our other, especially experts, are very helpful. The truth of the matter is that 85% at least of diabetes is managed in a primary care setting, and typically these patients aren't referred. So we have to make, we do manage the whole person. We have to make these decisions based upon the best data. Being purposely vague doesn't help me. I need something that's very, very specific that I can go to. So I think that your point, Peter, is a very important one.
Yeah, I think the truth is you're going to get the biggest bang for your buck out of the high potency statins. So that's certainly where you start. The issue then becomes, a healthcare society as well. I mean, I do believe, drugs such as ezetimibe have a modest reduction, but there's very little downside to it. And so I tend to be very aggressive, and even though that was a trial that studied patients post-ACS, in patients who still have residual LDLs that are elevated certainly around 100 or above, even above 70, I think there's a low cost to adding ezetimibe because you will get another modest reduction. I think where it becomes more problematic is now that we have new, very expensive drugs like PCSK9 inhibitors. Do I believe medically that if we added that on top of patients that we would get further reductions? Yes, but could we really ask the healthcare society to pay for that kind of price? I think for those kind of patients, you need to be very extreme values where we're targeting, they're at astronomical risk and we have to lower it. It can't be a population level.
There's a whole bunch of drugs that are not directly lipid related, that are diabetes related, if you will, if we can put them in that silo. A lot of available classes of medications out there. How do you go about beginning? How do you choose among all of these classes of medicine? What are these classes anyway?
Well, I think there's a number of classes. The problem is that often our choice is being limited by formulary restrictions.
Let's put the formulary to the side.
I wish we could, but in truth, I think pretty much everybody who can tolerate them would start with metformin, for type 2 diabetes. So you have...
That's old-fashioned stuff.
It's old-fashioned stuff that works very well.
Works well.
It's inexpensive, and about 80% of patients can tolerate it. When you don't have that, then you have another problem. Then we go into a stepwise approach, and frankly, all the guidelines suggest that each of the agents has benefits. You have to evaluate it in terms of cost and side effects. I always say that sort of safety trumps efficacy every time. So you really look at what the patient can tolerate. The newer classes of agents, the GLP-1 antagonists and the SGLT2 inhibitors, offer some real opportunities. We now understand that physiologically, it's not just insulin deficiency and insulin resistance. Basically, there's a number of different organs. DeFronzo talked about the ominous octet. Now people are talking about 11 or 14 physiological deficiencies. So addressing a number of those deficiencies gives us the opportunity.
Now, we have all these epiphenomenon with all these new drugs, right? They have effects on weight. There's certainly hypoglycemic effects. And when we talk about hypoglycemia, what I mean is physiologically significant low blood sugar that's pathologic. And then we also have prior cardiovascular disease as a risk. And we have kidney disease as a risk. How important are all these, and how do you weigh them?
Yeah, it's really important. We have to, and actually they're incorporated into the ADA decision-making algorithm. You have different criteria, which in a conversation with the patients, the anticipated efficacy, the anticipated effect in weight, whether it's a weight neutral, weight gain, hypoglycemia, adverse event profiles, and cost is part of this discussion. So obviously we went back maybe 20 years ago when our options were quite limited. Perhaps this narrative would have never even been considered. But nowadays, these profiles for the new agents, the modern era, of diabetes agents allow us to have this beautiful exchange.
We have an embarrassment of riches. Is
Right,
what you're telling
right,
me,
right, absolutely.
But still, every one of these things needs to be considered. If you put somebody on a drug and their weight goes up, then they're going to say, "But gee, I wanted to
Mm-hmm. Right,
lose weight."
right.
So-
And that's really one of the challenges. So you've got weight gain and you have hypoglycemia. You know, the problem is that the cheapest agents potentially, sulfonylureas, they are effective, but they do have weight gain and they have hypoglycemia. So you have a GLP-1 agonist that works very well that doesn't do those kinds of things, but sometimes they're priced out of the range for many of the patients. Plus, it's an injectable and you have issues that you have to discuss with patients there as well.
And how many patients do you have where you say, I have this great new drug, get a lower A1C, but you may gain 5 pounds? Say, oh, yay! So
Right.